I'm going to spend the next 15 minutes or so going over some cases. And these are just some cases from the lab. They're going to be CT based, looking at different types of abnormalities. And I'm glad we have Dr. Nabi up here because he can also help in terms of looking at this. This is a patient. These are just axial images that we're going to be scrolling through. This is the aorta over here, pulmonary artery, left atrium, right atrium, and kind of just see if there's anything as we're coming down. PA, aorta, right coronary coming into view, right here. And then there's this thing. So you have a choice in terms of what this might be. The patient had no significant disease, so just in terms of what there might be, you could have an anomalous right coronary artery, if there's a possibility, aortic aneurysm, coronary artery fistula, large pericardial effusion. Maybe you want to look at that again just to kind of see what... Here's the aorta. So the aorta doesn't look particularly big. Pulmonary artery looks a little big. The right coronary artery is here. There's no real pericardial effusion. So it's fistula, right? So let's see. Here's what this looks like on a 3D image. And we're going to take away some of the, you can see the right coronary here is very dilated. And this is a fistula, okay, from the right coronary artery up into the superior vena cava. So this patient had a significant left to right shunt. So here's the aorta, and this is now tracked out nicely. So you can see here's the aorta, and this is the fistula coming down this way. The right coronary is here, and it's coming down into the superior vena cava. So this was ultimately plugged by Dr. Lin. I don't know if Dr. Lin's here or not.
Just wonder how did the patient present, or what was the issue?
I don't know. The major problem with this patient was that there was evidence of right heart failure and shortness of breath. And the CT was done really as from, obviously more from an anatomic point of view to get a feeling for where things were. But actually, we see these not infrequently. We have several case examples. Some go into the coronary sinus from either the left side or the right side. Some go into the right atrium directly rather than just into the SVC. But it is an interesting case, and it is a nice case of left to right shunting off the coronary artery.
So there's a cautionary tale to this.
Oh, there's Dr. Lin. He was hiding behind Dr. Nabi.
So the other side is actually, this is, it's unfortunate we didn't coordinate too much because she actually has an excellent cardiac MRI. She actually also had about, I think, 1.5 to 2 liters per minute flow from a PFO, continuous left to right shunting. So it was actually pretty impressive. So she had been managed for about 15 years for diastolic heart failure, and it was thought that she had pulmonary hypertension secondary to diastolic heart failure. So what's interesting is she has a roaring, almost a palpable thrill. So at least 3 out of 6, almost 4 out of 6 systolic murmur due to that coronary fistula. So I think a quiet exam room and getting a chance to really examine the patient will sort of tip you off to start looking at other things structurally.
You used your stethoscope for these kind of things?
I did. So what was very unsatisfying was she still had a little bit of flow at the end, so she still had a murmur, and it was actually higher pitched, which is consistent with having less flow, right? But not as satisfying as when you can get rid of it completely. So
the key question here is, did you use the stethoscope before or after the CT scan?
Before, after. So actually, it prompts an interesting question. I don't really want to occupy too much time, but we had to actually diurese the crap out of this lady because, we were concerned she really did have elevated diastolic filling pressures, right? So the problem is if you cut off the flow from her PFO, so now she has no way of decompressing the left atrium, right? So if you close the PFO, she could potentially get into a lot of trouble where the left atrial pressure suddenly rises immediately after the procedure, because this is not like surgery, right? So what we wanted to do is we wanted to make sure that we had her absolutely dry before we did the cath. And so we did contemplate the idea of doing first the coronary fistula and then the PFO, because the thought process was the coronary fistula was giving her two issues. Number one, it was probably creating some ischemia that was contributing to right ventricular dysfunction, right? That's the first thing. The second thing was that it was certainly a left to right load, right? So we thought about that, but this lady was not gonna, she was really not gonna agree to 2 times to the cath lab. She'd already been cath multiple times anyway as it is, so we decided we'd just try to do it all at once. So we had to prepare her for the cath lab. So we diuresed about maybe 15 pounds of fluid off of her over the course of weeks. So I had plenty of time to examine her before, during, and after the procedure. So.
The other thing I just want to mention, this is the left atrium, this is the right atrium, and you see this communication here. But the problem is, when you have contrast on the right side, it's very difficult to know if there's a thin membrane that you might be missing here by CT. Even though there's high spatial resolution, you could still be missing a membrane. But it looks like there's a communication between the left side and the right side. Okay, let's go to a different case. Okay, so this is a 42-year-old woman with prior valvular heart disease and chest pain. And let's just take a look at this particular scan. So first of all, we're coming down, and this is the aortic arch. This is the descending aorta. It's the ascending aorta. Again, this is the descending aorta, the ascending aorta. Pulmonary artery. This is the ascending thoracic aorta, which now looks a lot smaller than what we saw down here in terms of the arch, etc. This is the aortic root down here. This is the left main coronary artery. And just moving down, this is the LVOT here. This is the left ventricle down here, left atrium here. Mitral valve here. This is diastole, the valve is open. So, I don't know, do you need to see any more of that? I think it's pretty well seen. Okay, so the question is, what is the diagnosis? Is it a DeBakey type 3 Stanford B aortic dissection? Is it a left atrial appendage thrombus? Is there a severe left main coronary artery stenosis? Or is there an aortic root aneurysm? So let's go back and look at those things. First of all, it doesn't look like a distal dissection, because there's also dissection up here, okay? Secondly, in terms of the left atrial appendage, you can see that here, there's no left atrial appendage thrombus. What about coronary artery disease in the left main? I don't see any plaque per se, but the left main looks awfully narrowed there, okay? But what is this thing? Okay, all right, well, that's a aortic root aneurysm, and if you look at it this way, you can get a better feeling for that. Okay, so this is the left. This is the sinuses. The right. This is the non-coronary sinus. This is the left sinus over here coming into view. So this is the left sinus of Valsalva. Notice the dissection here. This patient had a prior dissection 14 years earlier. So she was only 40-something years old, and she had that grafted, and she had AI, and she had the aortic valve resuspended by Dr. Lowry. And so she has a graft in the ascending thoracic aorta, and but now she's coming with chest pain and chest pain. So the question was, what about this? So you can see that there's actually left main compression between the left sinus of Valsalva and the pulmonary artery. The aortic root was 7.3 centimeters, and the left sinus of Valsalva was 6.8. Okay, so a rather impressive case, and you can see the coronary artery is beautiful. I mean, there's absolutely no plaque whatsoever in that coronary artery. So the patient went for surgery. She actually had replacement of the graft again, and obviously got taken the root out, and had to have a placement of an AVR. And now you can see the left main over here reimplanted, and so now all looks good. So reimplantation of the left main. But it's just an example. This patient obviously had a lot of aortopathy very early on in age to have a type 1 dissection, in her 40s, in her 30s, late 30s, early 40s. So anything the panel would like to say about this in terms of the...
Yeah, let me ask you a question, John.
Yeah.
If you had an algorithm which would tell you what kind of valve that was based upon the appearance of it, automatically, that we could basically show you a picture of what the surgical valve looked like, is it helpful to you?
Can I tell the type of valve?
Yeah.
Well, it's a mechanical valve.
Sure.
And, you can,
Yep.
I can't tell, I'd have to do it, if I thicken the slices,
Yep.
I could tell you exactly what valve it is.
Okay.
Yeah.
So if it was done automatically, does it add anything to your interpretation of this?
Well, I mean, this is post-op now, so this pre-op, it wouldn't have mattered because pre-op she had her own valve still, so.
I mean, ultimately it will be. And we discussed AI for quite a while.
No, one of the discussions we got is, I don't know if I want to say this in public, but it's to build a library, an image library of medical devices. Doesn't exist by both CT, MR, fluoro, which you can automatically basically match up what's the device that's been implanted. Because you don't see the whole valve here. You just see, of course, the metal pieces.
By thickening these slices, we can see the entire valve.
Absolutely. And you'd also be able to tell the difference between
tell the difference.
what it looked like when it was implanted,
Yeah.
which is what I'd give you, and then what it looks like
I'll tell you,
now.
Alan, a lot of times when I thicken those slices up,
Yep.
and I kind of know what the St. Jude's and all look like, but a lot of times I have to actually go to my phone
There you go.
and actually look up what valve it is because all the different valves, all the mechanical valves look different. But yeah, you can literally thicken these up and you can exactly see what valve it is. Yeah. Yeah.
Comparing with the aortopathy and the history of dissection, the big leak, this is a bicuspid valve.
I think this patient actually did have a bicuspid originally, but when she had her dissection, but this patient obviously had a lot of.
I mean, this patient is lucky to be alive,
Yeah.
right?
Yeah, with a type 1 dissection.
These are the patients that you don't want to. I mean, you don't want to leave alone. You'd like to keep a close follow-up after that initial dissection. She may not have,
Yeah.
but you'd like to keep in touch.
But it's kind of interesting. I mean, she did present with chest pain, and she had that left main was extremely stenosed.
One other question, John, is we have a patient at the moment, very similar to this, has got a persistent distal dissection, which is getting bigger. But there's some fluid or inflammation around the ascending graft. And the question that came back, because this would be part of a study, was, is that post-op change or is that infection?
Okay, stop right there because
Okay.
get ready.
Oh.
Case 3. All right, case 3. Look at this. Tell me about this. Okay, so there's a bioprosthetic valve, okay? Look around the valve. This was a patient who came in with fever with a bioprosthetic valve.
We did not coordinate these questions. This is purely by chance.
I mean,
we work
thank
very
you.
closely
Thank
together.
you so much for the introduction, Alan. Okay. All right, so we always look very carefully at this. You can see that there's increase in intensity here, attenuation around the aortic root. Normally that's surrounded by fat, so it's minus 80, minus 100 Hounsfield units. That is not the case here. So let's keep going on. And let's look at this. And again, what you see is that here, okay, and around the root is all of this darker area where it should really be minus 100 Hounsfield units, all right? The Hounsfield units here are 23, and it's stuck right underneath this left main, okay? That's the left main there, okay? And if you look at the valve actually looked pretty good. So here's the valve in motion. This is a bioprosthetic valve. Now you will notice that there is some thickening of this leaflets, okay? And you have to wonder if that isn't early endocarditis, where you still don't have a vegetation actually forming yet. So this patient, because of fever and everything, was actually treated for 2 weeks and then came back.
How early post-op or late post-op?
Oh, this is post-op, like several years. This is long out, okay? It's not early post-op. But now let's look. This is now 2 weeks later. We're going to get there. All right, so there's the aorta again. Ascending, descending, pulmonary artery. And I think you'll notice something. Well, the pulmonary artery is enlarged there, but notice that. That's exactly where we saw those increase in Hounsfield. This is 2 weeks later. And what is this now? This is now a pseudoaneurysm and an abscess, probable abscess cavity. Okay? And it's right underneath that left main. And in fact, when you look at it here, you can see that this is here's the valve. Here's the LVOT. This is where there's a hole going into the LVOT. Oh, I'm sorry. Here's the valve. Here's a presumptive abscess. This is a fistula going into the LVOT. If you look on this side, you can see where the hole is in the aortic root, okay? So this is a pseudoaneurysm with presumptive abscess and fistula, as you can see there. And if you look at this, I try to get it as best I could, you can see this is the hole around, this is a paravalvular leak, this is the abscess, this is into the LVOT, and this is the left main, okay?
You remember the case that Dr. Restrepo showed the first day? That's pretty much your CT angio correlate of a rupture in the LV outflow tract just below the valve with a sac, a pseudoaneurysm sac that has opened.
Yeah. So that's the left main. And incidentally, this patient, when he had surgery, not only did he have the valve, but he also had a left atrial clip put in, which you can also see. And, you know, to get at your question, Alan, now you know, there's more and more data coming with the use of FDG PET to really look at early evidence. And it turns out that the SUV levels, the amount of intensity of the FDG uptake is a pretty good indicator of, is there old just inflammation that's present, let's say early after surgery, just inflammation versus infection. And you can also do leukocyte imaging with PET to also look at that. And when combining the two of them, you can get a very good idea. You can take in this, by fusing CT and PET, you can get a very nice look at that. This is intensely hot, this area in here, okay? And this patient actually did have endocarditis. So with the introduction of PET, and that's just something we really want to get into in here when we start doing this, is because PET is a very good way to help tell whether those accumulations that are higher in Hounsfield units than what we would anticipate are just post-operative changes, or are they really infectious?
But back to Bill's question, you almost need that time course of post-operative changes. I mean, I don't know. I mean, is there anything that has looked?
There's no data.
Yeah.
Yeah.
So could we even say that by 6 months it should be baseline? By
I would
3
think
months
so.
it should be baseline.
I would think so,
I
but
would think
again,
so too.
you know, I would think in terms of the normal healing process, that 3 to 6 months would be enough time, right? But you know, very early post-op, a week, 2 weeks, someone has now high fever, you don't know. I mean,
These are the ones that give you a little nightmare.
Yeah,
You
absolutely.
have a graft, you have a composite graft at times in the ascending aorta,
Yeah.
and you see a little, I mean, we've described them from even the days of, early days of Stanley Crawford, where he did a lot of them here. And you have this little space, and is this infected, yes or no? Gradually it goes away with time, but I don't know what the time course of that is.
so I mean, this is an evolving area, but I think it's a very important one because, you know, we commonly see these problems. And we usually go by fever and whether they have positive blood cultures, but.
You have one more case?
Well, I can if you want. I mean, I have lots of cases, so I just, if you want one more. So this is just this particular study that was published recently. Okay, okay, this is actually a good one. This is one of Dr. Lin's cases. So let's see. So we're going to go through this. Again, this is the aorta, okay? Coming. Aorta, arch, coming. Okay, here's the pulmonary artery. What's this going on down here? All right, keep coming. Okay, left ventricle. So that's pretty much it. I think you got a pretty good look at that. The questions are, is this a type 3 Stanford B aortic dissection? Coarctation of the aorta, arteria lusoria? What is that? Aha!
Oh.
Or an intramural hematoma.
Must be arterial.
All right. So Alan will know what that is because, so coming down here, certainly, you might think that this is a type B dissection. You might think that, okay? But it's not, okay? And it's not arterial lusoria, which is where the left subclavian comes off the descending aorta. And usually then the tracks between the esophagus and the trachea, and usually you get cough and dysphagia and such like that from it. So it's not that. And let's see. It's not an intramural hematoma, which I do have examples of that, but we're not going to get to those. So it must be coarc by default. And this is these are the images. So this is the arch. This is the left carotid, actually. This is the subclavian. And right here, you see like a 99.9% stenosis of the aorta. Okay? So this is another view of it. These are actually collaterals. And so this patient had collaterals from the subclavian down to the aorta. This is another major collateral here. So that big thing that you might have thought was a dissection was not a dissection. That's a collateral coming off the aorta. And actually this went up to I believe to the left subclavian. They were kind of crisscrossed each other. So big collateralization is not surprising with a 99.9% stenosis, okay? So this patient went for stenting. And you can see a very nice stent here. Now look at that collateral. It's actually, there is some flow. I had a dynamic image of it, but it didn't load. But there's actually, you can see still some flow during systole into this partially thrombosed collateral now. This is a side view of the stent. Here's another view of the stent, very nicely placed. Whoever did this did a great job. Incidentally, in the old days, this is, probably Alan remembers, this is what they used to do.
Why that?
Okay, instead of stenting, they used to put a graft in from the ascending aorta to the descending aorta. This patient also had a bicuspid valve, and he actually had a type 1 bicuspid valve, a type 0 rather, which is not infrequently associated with coarc.
So what other imaging should this patient get?
Okay, so anyway,
Thank you, John, very much.
pleasure.